We're going to talk about PCV2 vertical transmission, and I have to thank Dale and Edgar for what they've done leading up to this point, because vertical transmission of PCV2 is very similar to what we know about PRRS and some other things. However, there are some nuances to this virus that I think we'll hopefully point out in this presentation. This is a relatively newer virus than PRRS, so to say, as we know in the research world. And hopefully this presentation will at least let you know the facts and what we know about vaccination and prevention and how to maybe manage that in the downstream flow. So we'll get started here. There's multiple different genotypes of PCV2, which we all know. And I bring that up because we talked about A and now B, which took over the global kind of most prominent strain back in about 2005. There's a nice shift from PCV2A to PCV2B. That's the most prominent strain. However, just want to point out that there is PCV2 C, D, and E as well, and these are kind of location specific at this point. What it's telling us is that PCV2, even though it's a DNA virus, has the capacity and the ability to mutate. Not as much as PRRS, but this capacity to change is what sometimes drives what we're clinically seeing. So I just want you to keep that in mind as we go forward. PCV2 is in the U.S., obviously. Most herds have virus or have seen the virus. When we look back at, we think about it, it's probably been only 6-7 years we've been talking about PCV2. But if you look back in the literature, we know it probably came here, at least in North America, about 1985 was when our serological antibodies tell us. And if you look back in Europe, at least it goes back to 1967 in Germany, where they do have antibodies to PCV2. So this virus has been here, and so the question is, well, how come it just started kind of seeing and causing problems here in the U.S. or all over the world? And you have to think that maybe it's part of that mutation process, so keep that in mind. PCV2 is also different than maybe PRRS or some other viruses in that it's a very protracted viremia, meaning it's a lot longer infection in general compared to these other viruses, which we're not used to. PRRS, maybe a couple weeks. PCV2, it can last up to 3, 4, 5 weeks. It's been pointed out by Dr. Albert Patterson that 210 days is, 209 days, is a length of shedding can be. So this is a very long time to clear this virus. Also, this virus is very unique in that it actually causes immunosuppression, or it attacks part of the immune system, which leads to this protracted viremia. So transmission of PCV2 in general is nasal, oral, or fecal oral. Those are the most common two ways. However, this virus can be detected or shed in anything that comes from the pig. You name it, urine, ocular fluid, nasal fluid, saliva, feces, and semen. We're not going to talk too much about semen in this presentation. I'll just give you the high points right now, but it can be shed in semen, but definitely at a very low amount. And from what all the research tells us is that it's probably not it is not a significant way of transmission. Is it possible? Yes, but the likelihood is very, very low for it to occur through semen. When it comes to aerosol transmission, can it occur? That we don't know. However, we do know it can be found within dust outside of a barn. The preliminary work for aerosol transmission is just starting to be done. So we don't know the infectivity of it at this point. Can it happen by other routes? Yes. Fomites, insects, rodents, we believe it can. However, we need to make sure, or we need to have the proof that it does that. We know it can be on needles. We know it can be on clothing. We just need to do the studies to make sure that it's a real finding. So we're going to get into the vertical transmission here, and we'll talk about dam infection. And dam infection can occur at any time point. Other pigs in the environment are actually the major source, but the environment is also very important because this virus is very robust, very hardy, and very difficult to kill. There's multiple different papers out there that tell you about the disinfection and how this virus lasts a long time, and if you don't have contact time or if you try to heat it, it won't die. This virus is very different than the PRRS virus. It'll be there no matter It'll be there a long time no matter how hard you try to get rid of it. The other issue is dams can get infected and then reinfected. It could be a different virus, potentially 2 different A viruses or 2 different B viruses, it doesn't matter. Usually after the waning of antibodies occurs. In general, though, dam infection usually occurs with new introductions to breeding farms. Usually it's the gilts, because they're a naive source that have not seen the virus that's potentially circulating on that farm, and they're the ones that cause the higher viremia and the shedding. With dam infection, you get sow infection. And with dam infection, you get fetal infection. With that, how it occurs is sow viremia. This is the most common route how fetuses get infected from the dam. PCV2 is able to cross the placenta and at any point during gestation and infect those fetuses. In addition to sow viremia, the sow can actually shed PCV2 in colostrum and or milk. PCV2 has been shown to be more common in colostrum. It's been shown to actually go out to about 28 days in milk. However, we really don't know the importance of the colostral milk shedding. We know it's infectious, we can tell you that, but the significance is unknown because when it's also in colostrum or milk, there's also antibodies there, generally to PCV2. So you don't know what's kind of occurring in the pig, and that's where some of the research maybe needs to go, is what happens if there's colostral shedding to the pig, but we don't know necessarily at this point. Fetal infection, if it occurs in early gestation, so generally under 70 days of fetal age. So what we usually have is PCV2 has a tropism for rapidly dividing cells, and in that pig, generally the myocardial-cardiocytes are the cells that are attacked. And what you end up with is fetal death due to heart failure. So myocarditis, necrosis, and fibrosis is generally the reason why the pig dies in utero. However, if fetal infection of PCV2 occurs after 70 days, 75 days, when the fetus is able to maybe mount a partial immune response, things change a little bit. The heart is no longer dividing as rapidly as it has been in the past, so that tropism of that PCV2 in the fetus changes a little bit to lymphoid tissue. So spleen, thymus, lymph nodes, etc., like we see in the growing pig. It's because those lymphocytes are the ones that are now kind of actively dividing. If infection occurs after 70 days when that fetus is able to mount an immune response, it can clear that virus. So technically there's the possibility of having a silent infection, a silent in utero infection. There's 2 options that may occur. The fetus may die or become infected or clear the virus. So we really don't, it all depends on some other issues, what's going on, what happens if that pig gets infected after 70 days of gestation. So this table just kind of depicts what are the fetal outcomes of infection, of PCV2 infection in utero. If it happens really early, the first trimester, there's a whole lot of different things that can happen. Typically, early embryonic death and irregular returns come into play, just because the whole litter is usually killed. Whoops, I apologize for that. Pseudopregnancies and small litters are also noted. If it's generally mid-gestation, second trimester, we get a lot of mummified fetuses. If infection is so high in the early part of gestation, what happens is they all die and they get reabsorbed because fetal mineralization of bone doesn't occur until about 35 days of age. So that's why we kind of have these other things before we actually have the mummified fetuses. After 70 days, when they can make that antibody response, there's a whole gamut of things that can possibly happen. Anything you can think of that causes or associated with reproductive failure can be seen. You can have mummified fetuses, you can have stillborns, you can have weakborns, you can have normal-looking fetuses, and I think that's the point that I really want to point out, is if it does happen after 70 days of gestation, you could have a normal fetus being born that's potentially already infected with this virus. I have abortion on the screen here, and I just want to point out that that has been noted, but is very atypical of vertical transmission of PCV2 is to have an abortion. Generally, it's you don't see that. So we just kind of went through what can happen, and I just want to make a very important distinction on the outcomes in fetal infection. There's generally three things that can happen, and the first two are most important. There's one, we can have something called PCV2-associated reproductive failure, which would be very similar to PCVAD. Or the second thing is PCV2 in utero infection, which I would equate to like the subclinical PCV2 infection in growing pigs. The other option is nothing, right? The null hypothesis. These top two things can differ, though, depending on clinical signs of what you might be seeing, the age of the dam. We obviously talked about fetal infection and how you diagnose it. So I really want to get this through your head. There's two different things. There's the clinical disease and then the subclinical disease. That's important to having to understand this vertical transmission. We're going to start with the associated reproductive failure. This one is the easiest to kind of explain because it's full-blown disease. It's most commonly seen or associated with naive dams. So generally seen in all gilt farms, gilt entries, or repopulated farms. All right. Clinical signs, really you don't see nothing in the dams. It really doesn't cause a fever like SIV or PERS probably does. What you end up seeing is when these sows are farrowing is the damage. You usually find increased non-viable pigs. So mummies, stillborns, and weak-born pigs are the most common finding associated with PCV2-associated reproductive failure. Again, we did talk about abortions, but this is a very minor case. You usually don't see abortions. Usually the biggest thing is the non-viable fetuses. So this is what PCV2-associated reproductive failure looks like. All right. To most people, they would say, that's parvovirus. And I would say, great, because whatever you know about parvovirus, it's the exact same thing when it comes to PCV2 in a sow farm. Generally gilts, don't see nothing until they actually start farrowing, and all of a sudden, oh my gosh, we have these stair-step mummies. So drill this in your head. PCV2 looks exactly like parvovirus when it comes to that. So you have fetuses that are somewhere around 40 days of age to these bigger mummified fetuses and some stillborns. And it's easy to diagnose at this stage because we can still find PCV2 in there. If you want to open them up and sometimes get lucky, some of these stillborns you might find an enlarged heart or increased hepatomegaly or a lot of thoracic fluid indicating heart failure. But in general, you're going to have these nice stair-stepping mummies. I do want to point out, though, this is the classic picture, all right? This is beautiful, small to big. It doesn't have to be exactly that way. You could have just a couple mummies or just a couple stillborns. You don't need to have the whole stair-stepping litter effect. All right, we put these beautiful pictures up here because we're pathologists, and they're great. They prove the point. But ultimately, when it comes to the field, you got to recognize that if you even have a couple mummies, that it's potentially PCV2 involvement. Real quickly on some of the background of PCV2-associated reproductive failure, it was initially reported in Canada in '99. Funny, that's about 8 years after it was actually reported to cause clinical disease in Canada. When they went back and looked at some retrospective studies, they couldn't find PCV2 in fetal reproductive cases. I don't know why. Maybe they didn't get submissions. Maybe everybody thought it was parvovirus and didn't submit it. However, they couldn't find anything prior to that. Korea did the same thing. Basically, they found more of about a 10% cause of reproductive failure was associated with PCV2. Since that time, more studies have been done to determine what's the actual prevalence of PCV2-associated reproductive failure, and they've done some prospective studies. And I just got them listed here. Germany, Spain, Brazil, Czech Republic, and so forth and so forth. It varies between country, and it varies the amount. And we don't necessarily know why. Could it be virus? Sure. Could it be practices? Sure. We don't know. but we can find it all over the board. But what I'm trying to point out is that when you add all these estimates together from across the world, you end up with about a 10 to 20% reproductive failure rate that's probably associated with PCV2. Meaning, 1 out of every 10, 10%, 1 out of every 10 reproductive failure cases is probably associated with PCV2. This is done, these estimates are prior to vaccine use and development, keep in mind. And so I thought that number seemed kind of funny to me, just because we don't see a whole lot of this at the diagnostic labs. So I went and pulled the data from the last 8 years. And we ended up with 501 reproductive failure cases at the diagnostic lab. When it came down to it, 58 out of the 500 were associated with PCV2. That gives us a 12%. So in essence, our estimates from all over the world, and at least Iowa State, suggest that, 10 to 20% of all cases, PCV2 has involvement. I want to shift gears now. That was PCV2 associated reproductive failure. Now I want to talk about the in utero infection, or the subclinical infection that we might call it. The interesting point of this is it is much more common than the actual clinical reproductive failure. Much more common. All parities are affected, not just gilts like we see with associated reproductive failure. So it could be a P1, it could be a P8. Doesn't matter. Potentially they could be transmitting this virus to their offspring. Is there clinical signs? Nope, because it's subclinical, right? Occasionally you may get a few weak-born pigs as possible. Occasionally. The most difficult part, though, is trying to diagnose subclinical infection. What you need to do at that point in time is the best thing to do is to have pre-suckle serum samples to diagnose in utero infection. We can do pooled PCRs for viremia. We can do ELISAs or IFAs to determine if they have antibodies that were generated in utero. There's multiple tests you can confirm it that way, but it really needs to be pre-suckle, because if they suckled, then we don't know what those antibodies are, and potentially milk had the virus in it, so we don't know if that viremia is true or it's actually induced by the milk. So in general, the diagnosis is much more difficult, because that means much more labor-intensive way to get the samples that are needed for diagnosis. To prove my point a little bit, what's the prevalence of PCV2 in utero infection in the United States? There's a fairly big study done by Dr. Preston a couple years ago, where she had looked at 5 sow farms across the U.S., Minnesota, Iowa, Missouri, Texas, and one in Mexico. And we took 100 piglet samples per farm, is what they ended up was the sample size, and we looked at individual viremia pre-suckle samples. And what they found was that overall on those 5 herds, so 500 piglet samples, 100 from each sow farm, overall 44% of those piglet serum samples had evidence of PCV2 viremia or previous infection. That's a big number. Sow farms varied a little bit between 17 and 71%, depending on where they came from. Interestingly, Korea actually repeated the exact same study and found about 33% of in utero infection occurring. I want to make a note that this stuff was before vaccine use in sow farms and incoming gilts. They repeated that study, that's what's in the box over here, with just recently, and these farms that were used had dam vaccination, meaning gilts were vaccinated prior to entry. That was it. And what they found is that, yes, with just incoming gilt vaccination, we reduced the presence of in utero infection to less than 1% to 22.8%. So even just vaccinating incoming gilts drastically reduces the potential of vertical transmission of PCV2. There's all sorts of anecdotal reports as well. Some actually in proceedings papers which say that dam vaccination within parity segregations or other instances greatly reduced to sometimes a non-detectable level of vertical transmission of PCV2. What I'm trying to point out in this case is that it looks or it appears to be that vaccine can do a heck of a job in reducing the transmission, vertical transmission of PCV2. This is my attempt at trying to explain the differences between the subclinical, which is PCV2 utero infection, versus the clinical, the associated reproductive failure. And the reproductive failure is going to have the mummies, the stillborns, going to be primarily gilts, very easy to diagnose off those fetuses. The subclinical aspect can be anybody, gilts, all the way to P8s. It's much more common, that's probably the most important point, and it's much more difficult to diagnose. You probably need pre-suckle samples to do so. So the more interesting part is, well, what's this all mean, right? So I got PCV2 in utero transmission. So what? Well, that's where literally the research needs to go probably, but I want to point out some of the things that we do know. We do know that there's a litter effect, meaning that dams that are possibly viremic at birth, their offspring have increased mortality and morbidity in the growing phase, and there's more incidence of PCV So we know that it's not good to have vertical transmission. Is there persistent infection? Potentially, I think the word persistence we associate with BVD, but persistence just means long infection. So I think, yes, there's a potential for a persistent infection, but at this point it's kind of unclear. And we really don't know how maternal antibodies play into that effect of, if the pig's born viremic, it gets maternal antibodies from the dam. Do those maternal antibodies really clear that virus from that piglet? I don't think we know the answer to that. Will it not be viremic? Yes, probably. But will it hide out in tonsils or a lymph node or bone marrow or something like that? I think it possibly can, and then maybe later in life it actually can become viremic or cause disease. At any rate, it is known that potentially in utero transmission is not good for the virus, or is not good for the piglets. And I want to point out two separate studies, but the first one, this is the most interesting. What they did is they infected piglets in utero, about 90 days of gestation. These piglets were born, looked absolutely normal, but they were already infected with PCV2. They did a couple things. They divided them into groups, and what they did is they either infected them with parvovirus or immune challenged them with keyhole. And to point out the fact is that the ones that were infected with co-infected with parvovirus or immune challenged with keyhole actually developed PCVAD, where the other groups did not. So the point being is that it appears that, in utero infection does the same thing as it would to piglets in the growing phase, where the virus modulates the immune system and makes the pigs more susceptible potentially to other factors, other viruses, or other infections. They should also show this in Korea with porcine epidemic diarrhea virus, the exact same thing. More PCV2 that was involved in utero actually caused more severe disease just after birth with that other virus. So keep in mind, yes, the same thing we know that happens in the finisher can happen in these just born or just weaned pigs if they were in utero infected. I'm going to shift gears for the last couple minutes here. We're going to talk about vaccine and prevention. Hopefully we understand the difference between in utero infection and reproductive failure and what we'll kind of look for. But now we're going to talk about how do we prevent it. And there's multiple vaccines on the market. They're all made against the PCV2A capsid. However, we know that B is the most common type in the U.S., and we do know that it does cross-protect, so that's the good thing. The interesting point is they're all labeled for pigs greater than 3 weeks of age, and I'm pretty sure a gilt or a sow was older than 3 weeks of age, so technically you can use these vaccines in a sow farm scenario. I break the benefits of PCV2 vaccine down by primary effects and secondary effects, meaning primary has visible or known effects on the sow herself. The secondary ones are the added benefits that we get to see. So when it comes to dam vaccination, what has been shown with PCV2? Well, we know that after vaccination, PCV2 antibodies are generated, and it drastically reduces the chances of having associated reproductive failure. So you really don't see the mummies, you really don't see the stillbirths, and so forth. We know that it can pretty much wipe out the clinical signs of in utero infection. We also know that the vaccine is very good at decreasing salviremia, no matter which one you use. Decreased PCV2 has been shown, in utero transmission has been shown in multiple studies. It also reduces the colostral shedding. And the coolest part about the whole thing is we don't think about it too much, but it's the exact same thing as kind of the homogenize or the PERS aspect of herd closure. If you actually do vaccinate, there's actually a really nice paper that shows, yes, your serum homogenizes with antibody level, and that corresponds with your colostral antibody level as well. So basically what happens is you have a really nice homogenized, potentially uniform group of girls within the sow farm if vaccination occurs. So what are the secondary effects? I mean, what are the added benefits that I might see if I choose to vaccinate my sow farm to reduce the transmission of PCV2? There's 6 of them up here. I want to let you know that a lot of these, or all of these 6 things, were significantly different or statistically significant. And this is accumulation of about, I think it's 415 sow farms, but they're mostly from Europe. But they are important. What you see is we've known that decreased wean to service first service interval, decreased sow mortality, decreased pre-wean mortality in the piglets, so forth and so forth. And the most recent one is increased weaning weights that has come out. If you do vaccinate your sow farms, it appears that you do get a heavier weaned pig. Some other noted changes beyond what was already been stated. And these are probably anecdotal, but it appears that there's better overall reproductive parameters when you use a vaccine in your herd. Just in general, it kind of boosts everything up. And that kind of makes sense, knowing that this virus is probably doing a lot of immune modulation. But it appears from multiple studies that we do get an overall better reproductive response. The really cool things that I find interesting, though, is that this has actually been published, and they're significant, that if you vaccinate your dams and your wean to finished pigs, or nursery growth finished pigs, whatever you want to call them, you actually have decreased nursery and finisher mortality compared to groups that were just vaccinated at weaning. So there is, for some odd reason, there appears to be an added benefit from vaccinating both dams and piglets when it comes to how they perform downstream. So that's just another point of the increased average daily gain that's been shown in those studies. So it appears, at least in what's been published, that vaccinating the dams is highly beneficial. But if you do decide to vaccinate your dams, there's a couple things we want to keep in mind. One is timing. For me, replacement gilts are a must when it comes to vaccination. I will probably stand up here on a soapbox till the day I die saying that you need to vaccinate your incoming gilts to a sow farm. Just because if you only vaccinate them once as a growing pig, the duration of immunity is probably waned by their 6 or 7 months of age. Also, your sow farm is now a new source of infection to that incoming gilt. So timing, yes, I would definitely vaccinate replacement gilts. Would I do sow farm vaccination? Most likely, in some instances, but I really need to think about the timing. It's not a normal pre-farrow, so 3 to 5 and 3 weeks pre-farrow. I probably wouldn't do that because we'd be supplying too many maternal antibodies to those piglets. So post-farrow or pre-farrow, I would definitely do after weaning, after farrowing, somewhere in there. Then you get the benefit of the entire gestation period of trying to protect those in utero fetuses. That's the goal, is to protect the gestation period of that dam. Real quickly on maternal antibodies, because I think they're important when it comes to PCV2 or other viruses. But in general, for PCV2 maternal antibodies, this protects piglets from disease but not infection. The dam levels vary within herd and between herds, meaning each sow on your sow farm is different if they're not homogenized. You could have one pig that's got really sky-high maternal antibodies, or a dam that'll give a lot of antibodies in her colostrum, or one that will not give as much. Also, each piglet takes up a varying amount. Piglets that are born early in the farrowing process uptake more colostrum, will have higher antibodies than those that are born last. PCV2 half-life of antibodies is around 3 weeks and has been shown to possibly last about 18 weeks. One good thing is that maternal antibodies are generally about the same in colostrum as they are in serum. So you can kind of equate what your serum antibodies are, what you'll actually be giving to those piglets via colostrum. So I think the biggest thing in everybody's mind, is there maternal antibody interference? That's a big question. There's scientific data that states yes. There may be a little bit maternal antibody interference with vaccinating of piglets. Others have said no, I can't find any. I don't know where if you ask me, I probably stand on the side that says yes, there is maternal antibody interference. There could be a slight amount, just because of all the data that's been presented through multiple field studies that you guys have run. So my point being is, sometimes you have to look to the fact that there may be some maternal antibody interference of why you might be seeing PCV-AD downstream in your vaccinated pigs, rather than maybe blaming it or trying to charge of mutant virus or something to that effect. I don't know, but potentially you always got to know that there is a chance for maternal antibody interference when it comes to this virus. So I have 3 minutes left. I'm going to sum this up real quick. Would I do dam vaccination in my sow farm? To be honest with you, I'm going to have to say it depends. And it depends on the overall herd stability that I have within that sow farm. If it's a clean herd, I probably wouldn't do much. I'd probably just vaccinate my incoming gilts and be done with it. However, most of the data from the sow vaccinations points out if you have a herd that may be PRRS positive, may be SIV positive, may have microcirculating, have other disease problems, I would definitely probably recommend PCV2 vaccination of that herd, because you are just going to minimize the effects of PCV2 and enhance your immunity to the other ones. So in those instances, yes, I would probably consider PCV2 vaccination. So yeah, take-home points would be, you can have PCV2 reproductive failure or subclinical infection. Subclinical infection is much more common. Reproductive failure primarily manifests in dams, and what the main clinical sign is mummified fetuses. However, in utero infection is more common and can predispose those piglets to other diseases after they're born. Dam vaccinations are shown to decrease reproductive disease and so forth, and increase the stability of the herd. And the last thing, vaccination timing strategy is important to ensure that your piglets won't have maternal antibody interference when you try to vaccinate them down the road.